return back home and thanks them. So the aberrant subclavian artery is not a new sign. I could have shown you other one. How many of you, I will not say are doing routinely, but let's say they do it regularly in some conditions? To look at the aberrant subclavian artery. Okay, so I'll guess it's one quarter of the audience. So the one who are doing this regularly, they have occasionally or more often headache, but occasionally they are happy that they did it. Again, to recall the anatomy, you see here the aortic arc, the ascending aortic arc with the brachiocephalic artery bifurcating in the right subclavian and right common carotid artery, and the left common carotid and left subclavian. And you see this red vessel is the vessel perfusing the right arm. And this is the normal condition. And in the ARSA, the aberrant right subclavian artery, this vessel is rising at the end of the aortic arc, just before the isthmic region, and courses behind trachea and esophagus toward the right arm. That means you see the aortic arc has 4 vessels instead of 3, and the last one is the one going to the right. Now, this here is from the internet. I can imagine that you can better understand what's going on here, and this is a view from posterior where you see the aortic arc and how the right arm is perfused by this artery. Now, in order to understand what's going on, I think embryology is not the easiest way, but if you understand some principles, you may understand what's going on. Under normal conditions, the embryo at early stages, 6-7 weeks, has kind of double aortic arc by definition. And what we have here is, this is the left and this is the right. We have the left common carotid artery and the right common carotid artery. We have the left subclavian and the right subclavian. If you forget, it's easy. We need one vessel to the right arm, one vessel to the head, one vessel to the head on the left, and one vessel to the other arm. Now, under normal conditions, this part will disappear by apoptosis, and since blood will go this way to the descending aorta, these 2 vessels will merge and build together the brachiocephalic artery. In the fetus, you have seen before what happened is this part disappeared, and we still had a left ductus, and this is why the arc was going to the right, and what we have seen was a brachiocephalic artery, but a mirror image going to the left. That means these 2 were in the other fetus going to the left. So in the condition of the aberrant subclavian artery, because this should disappear, it is very close, this part disappears. And this arc is open, and at the end you'll have the aortic arc going to the left, with the first vessel is the one going to the head on the right side, then the common carotid on the left, then subclavian on the left, and as the last part of the vessel, the left subclavian, the right subclavian going to the right. This is why it is here, and the other one is there. Now, it seems that the first one describing was Bayford, but it seems also that the one who did the drawing did wrong. He assumed that the reason of obstructed deglutition in this patient, well, it was in post-mortem diagnosis, he put this vessel between the trachea and the esophagus, a condition, let's say, not really seen in humans, and such a case is extremely rare. Probably they assume that he did the mistake and it should have been behind. Actually, the true description of this vessel was done at the same hospital I was working at. It was at the Charité by Comerel and co-workers. He described that the esophagus was shifted by a vessel coursing behind the esophagus, and he called it the arteria lusoria, or the abnormal course of the arteria subclavia. And this kind of bulging, this is called until today the Comerel diverticulum. Now, if you want to know the story, what happened, it's a very long story. It was, you see here the day, it was June 2003, exactly 10 years ago. I was working in the unit, and we received the patient, 42 years old. She had a nuchal, which was normal. She had an invasive showing Down syndrome, and she came for termination. My colleague called me that, can you have a look? I don't see any abnormalities on this fetus. At that time, I was preparing a paper I never published, actually, on the right aortic arc and development and so on, and read a lot of, let's say, book chapters on the development of the aortic arc. And every time I read on the left arc with the right aberrant subclavian, there was one sentence saying, in Down syndrome, it's very common. It was described in Down syndrome. And there were 2-3 papers from the 50s. Then I scanned this lady, and I wanted to check for the 3-vessel view, and I saw something color behind, and saw that the vessel, I followed by color and went into the right arm. I said, wow, this is probably the right aberrant right subclavian artery. And I remember very well, many years ago, my cardiologist, the pediatric cardiologist I was working with, he told me, we had just a baby with Down syndrome having nothing, but he has an arteria lusoria. And you know that I never heard about it. I remember in my medical studies I heard about such a vessel, but I doubt that we can see it. No, it's prominent, you should see it. And that day I said, it is this vessel. And I took the book again, and I saw this. I said, this could be a sign. And I rendered on color Doppler. That time it was very popular to do everything with 3D. And yeah, it turned to be true. And we terminated the pregnancy, and it was Down syndrome, of course. And I started to write a case report. But before doing this case report, I said I wanted to see how this is there. I went to the pathology. I had a good friend there, and organized the photographs. That I want to see what I saw on ultrasound. And this, when we opened the thorax, what we saw the right common carotid artery. And she told me that here in this region, you should see the bifurcation toward the clavicle, but this vessel is behind. So, and then we removed this package, and then I said, I want exactly the plane I was seeing in ultrasound. And we did the 3-vessel view with the trachea here, and I put the aberrant subclavian on the right side, and this is the left subclavian artery. And then I tried to get exactly the same images, because I said, well, it's an interesting case report on a rare anomaly. Probably no one had seen this with this combination at that time. So while I'm writing this paper, the next patient came with Down syndrome. I saw the same things, that wow, now I report of 100% occurrence if you have 2 cases. And then summer passed, and then we had the next case. I said, well, if I have occasional cases, I will do a series. And we checked 14 cases, the consecutive one, and we found it in five. This is what we published then in American Journal. And what was interesting, I was at that time at a meeting in the US, somewhere in Scottsdale or in Arizona, and I took the flight back with John Hyatt and was telling him about this new sign. And he said, you know, when we were working on the nuchal and so on, we saw a lot of aortic arc abnormalities in Down syndrome fetuses, but we couldn't, because it's small fetuses, classify them and so on. But there were a lot of branching abnormalities. And I'm grateful that Greg Dovor helped me in writing this paper, and then we published this in American Journal as an observation. And in the meantime, many people were doing this. I took every other plane away in order to make it simple, and the message was, once you look at the 3-vessel view, go a little bit higher to recognize the normal subclavian, and otherwise, if you don't see it, go for the 3-vessel trachea view and get the color down in order to see behind the trachea how the course can be. I removed all the 3D stuff and the projection I was doing and so on. This is why the main message is, take this plane, and in the 3-vessel trachea view, behind the trachea, you reduce the PRF, use color Doppler, and you see whether either you should angulate, you have toward the transducer or away from the transducer. You see it in red or in blue. Now, people ask me, how should we do it? I tell you again the message. You reduce first the color velocities until you visualize pretty well the pulmonary veins. This is the best preset you can get. Then you look at the 3-vessel trachea view, and you focus if you see a vessel behind the trachea. If you don't see, sometimes you see, of course, here you have to be careful. The azygous vein, as we're seeing in the talk of Kai and in his live demo. And you check if there is a vessel behind. If you don't see an aberrant subclavian, then you move further to the upper thorax at the level where even you may leave the aorta, and then you see an S-shaped vessel going toward the clavicle. And this is how it's done. The color is low. You see the pulmonary veins. You see here this red dot was the azygos vein, and then in the three vessel, we went up until we see this S shape. This is the clavicle, and this is the vessel. This is the trachea. I'll show you again. I stopped here. This is the azygos, and you should not misdiagnose this as an aberrant. The aberrant will go here long. And then we continue. We go a little bit higher. In this plane, you don't see the aberrant subclavian artery here. We just see the red vessel I will speak about after the break. And then this region, you see the normal subclavian artery and the subclavian vein. You see here the shape of this vessel under normal conditions. You see the aberrant subclavian artery. And Dylan Lewis, who was sitting here in the audience, described another approach that you can see it in the anterior-posterior view as well. And we published a paper on, let's say, that 4 vessels can be occasionally seen in the projection of the aortic arc. And Edwin Quarello described also the rendering with 3D. But at the end of the day, all are additional tools. The easiest way is really straightforward to look at the 3-vessel view, reduce the color, or use sensitive color like power Doppler, and then see that the vessel is going there. And in the meantime, of course, you can do it if you want to implement it in your genetic screening at 13 weeks gestation, even earlier. The earliest, and you see here, this is 22 weeks with color, with 3D rendering. You can see very well because you have the projection. The earliest occasionally case I've seen was at 10 weeks gestation because she was supposed to come at 11 plus before holidays, but it was 10 weeks. And I saw, you see here behind the trachea. And honestly, it's easier 10, 11, 12 weeks to see it than at 35 weeks or 32 weeks because at this stage, the arms are higher than the plane and you don't get the easiest plane. But I asked, actually I didn't ask, I tell the lady at that stage because I cannot tell something I see the first time. I will say we'll control it, but we did nuchal and biochemistry, everything was normal and the risk was not set high. And this is here, the same fetus. You see here, this is in March, the other one was in February. And this is the same fetus as 12 weeks with transvaginal scan and with the stick and the 3D rendering, you see the aberrant subclavian artery. Now, occasionally there are cases which make you wake up, say, wow, it's good that I did it. Sometimes I'm asked, are you obliged to do it in first semester? If you do the first semester scan and you look at some additional signs, it's a pity to let a woman go home and discuss this stuff at 22 weeks because you were lazy to look at the vessel early. If you are able to do it, so go ahead and do it. And this patient, 30 years old, she had nuchal and biochemistry with a nice result. And then I did, let's say, the nuchal was okay, and I assumed to see a nasal bone, and then I went to watch the subclavian, and I saw an aberrant subclavian artery. I said, what to do now? If I add the nasal bone to my calculation, she will get risk 1 out of 4,000, and I shouldn't exaggerate with this sign. I said, and then in that moment, I said, okay, I returned back and did everything another time. And I was not sure for the nasal bone, so I went to check for the nasal bone. And sometimes I prefer to take another angle. I hit the baby a little bit, and then went until to get this plane. So I said, I'm sorry, I don't see a nasal bone. I see an aberrant subclavian. The risk is 1 out of 1,000 something. You should be out of the range, but let us do an invasive. But you know, I said, no, I don't know. I don't want to hear, but you know, I will. This is what I have to offer you. And these 2 signs are really the biggest and the major sign you can use for depiction as additional signs and it was Down syndrome. I had a recent case 2 weeks ago, also in a 30-year-old lady with a combination of 2 findings. Now, what is the frequency of this sign? In a nice French study on 144 fetuses, this hidden message, SCDRO, is the French word for ARSA. Sous-clavière droite, and I will tell you, I know it, but I forget it now. And 14% of the cases, this is the lowest frequency I know in a study. And I put together what I have until now. I may have some missing, but roughly the first paper we had was 36%. Zalel Yaron sitting here, he had 37%, 3 out of 8 cases. These data we presented at a meeting of Kypros many years ago from our office. We had roughly 20%. Borenstein from Kypros group, 29%. Palladini, 27 out of the 100 cases, the largest study, 25%, and Yagioglu from Turkey, 35%. Roughly speaking, 26% of the cases. The good news for many is that this is a normal variant. And since you have a normal variant, because it is present in 1.4% of the population, it means roughly 70% have an aberrant subclavian. 70% means in 490 persons we have 7. 7 in this room have an aberrant subclavian artery. 7. Who are these 7 persons? And if you tell your, sorry? Look at the nose, yeah? But you have to take the list of. Now, the issue is if you tell the parents, you may have problems. Either it's Down syndrome, but if it's not, you may have problems in swallowing later on and so on. You should assume that every 70 patient has a swallowing problem, which is not the case. This is why the all majority of persons are, let's say, normal with this condition. This is why we should not make out of it an abnormality. Since I've seen a couple of cases where the first child has a right arc, the second child has an aberrant, twins, one with Down with an aberrant, the other one without Down with an aberrant, the genetics say it's obvious. If you have 1.5%, you should have an autosomal dominant trait. And there was, I think, case report published by Dylan Lewis that the mother, or at least 2 mothers and the 2 children had such a condition. You should also consider that this can play also a role. If it was easy to detect, I will scan all the parents as well, but I know it's postnatally extremely difficult to get to this region to see if it's normal or not. So let's now come to the data you need, and I think this is a very, very, very important paper for you, but let's say the only thing I don't really like that only 2 studies were the basis for this analysis, but I trust Kypros by default. This is why this paper just appeared now in the White Journal, analyzed these markers: echogenic focus, ventriculomegaly, nuchal fold, not the first trimester, the second trimester, nuchal thickness, echogenic bowel, hydronephrosis, humerus you should remove because it should be out of the list, I don't know why, the short femur, the ARSA, and absent nasal bone. And they said that if you use the detection rate for these markers, these are here, and if you use the positive likelihood ratio, that means the number you should to multiply, you have to multiply, and you see the highest one were ventriculomegaly, ARSA, and absent nasal bone. But the good news is if you find a so-called isolated sign means you are ruling out the others. You are not saying, I see it's isolated. You should say there is no echogenic focus, there is no ventriculomegaly. And when you see that all are absent, and also this prefrontal edema and so on, you have an increased risk of 4 times, which is acceptable today, but you should be sure that this is mid-trimester. And when I see you, when you send me some videos from time to time at 16 weeks, we cannot use this because the ventriculomegaly, some other things are not valuable at 16 weeks, and some are not useful at 13 weeks. But let's say it is a high likelihood of 20% of the cases, or even 30% detection rate, but still we can work as an isolated sign with 4 times increase the background risk. So I think this is a good message for now. This is why I can conclude by saying it is still a normal variant, but compared to the other normal variant like echogenic focus and so on, it has big power to detect, on one hand, chromosomal aberrations. I spoke today only on trisomy 21, but the presence or its association with the cardiac problem increases dramatically the risk for 22q11. And very rarely, as I told you, the 7-1 were not eating at lunch because they have dysphagia with lusoria. It's not true. This is why all other persons are normal. We have one child We have seen now roughly 350 cases. We have one child where the parents, after 1 year, said there is a problem, but this child has a deletion on the 21 chromosome, not detected prenatally. We did invasive, and there was some growth retardation, and our geneticist says, no, this is a problem of the syndrome with this deletion rather than it has an operation for the subclavian artery, but I hope the child will do well. This is why if you have combined signs in the fetus, you can augment the risk by 20 times the background risk, but if you really find it's isolated, then it's 3 to 4 times the background risk. So I hope it can help you, and thank you for this for attention for this talk.